Okay, good morning, good afternoon, and good evening, wherever in the world you might be. My name is Safwan Masri. I am Executive Vice President for Global Centers and Global Development at Columbia University, and it is my great pleasure to welcome you all on behalf of the university to this webinar. Today is day 3 of our 5-day symposium exploring the history and current status of COVID-19 vaccines, a single theme with a multiplicity of dimensions. On Monday, our inaugural session was introduced by Columbia University President Lee Bollinger. Our keynote speaker was Sir Jeremy Farrar from the Global Wellcome Trust. This was followed by a panel discussion addressing the national, regional, and global response to the unprecedented challenge of producing and providing vaccines. Yesterday, we turned to distribution and how to satisfy global demand in a timely manner with Dr. Tedros Ghebreyesus, Director General of the World Health Organization, as our keynote speaker. Tomorrow, we will hear from Dr. Anthony Fauci in a session that will focus on the role of government and industry collaboration. And finally, on Friday, we will examine what we have learned over the course of the past year and how this experience will inform future vaccine development. We will have 2 keynote speakers, Dr. Munsaf Slawi, former Director of Operation Warp Speed, and Dr. Ezekiel Emmanuel from the University of Pennsylvania. In today's session, our guest speakers will explore the successful global administration of COVID vaccines and the ethics of vaccine prioritization. The Bill and Melinda Gates Foundation is tackling that challenge, and we are excited that today we will share with you Melinda Gates in conversation with CNBC's senior health and science reporter, Meg Tirrell. I am also pleased that we have with us today ethicists Dr. Ames Dhai from the World Health Organization and Dr. Ruth Faden from Johns Hopkins, as well as Dr. Mukesh Chawla of the World Bank and Dr. Peter Hotez from the Baylor College of Medicine. Overcoming vaccine hesitancy and urging us all toward herd immunity is, as we now know, only one facet of the challenge presented in this moment. The managerial expertise, from coordinating logistics to providing safe venues to ensuring that there are trained medical staff, is demanding. But beyond that, there is a compelling need for a rare and sensitive guiding wisdom. We are responding to a virus that affects the entire world, which requires that we coordinate compassionately as a global community and in ways that perhaps mimic the virus's indifference to borders, whether geographic, economic, or political. The vaccine rollout must feel just, in addition to being effective. The forethought, humility, and flexibility required are daunting but essential. In this historic moment, we must understand the benefits and consequences of our long-term approach to healthcare, which focuses on the unique needs, desires, and perhaps especially the resources of individual patients. Medical ethics is usually assumed to mean patient rights to privacy, confidentiality, and informed consent. The pandemic and suggested protocols for public health measures have thus inspired, in some quarters, an assertion of personal rights to not wear masks, to not socially distance, to reject vaccinations that ignore the public good. Western culture, in particular, is concerned with advancing the cause of individual liberties. It lacks practice with defining moral standards of right and wrong that are communal and based in what is right for a society as a whole. The part of the Hippocratic Oath we remember says, "First, do no harm," reflecting this understanding of medical ethics as applied to the individual patient. But Hippocrates also said that our duty is to alleviate the suffering of the people, a mission that sounds more like public health and a healthy regard for the well-being of all. And yet, it is all so much more complicated than rights versus virtues, or personal choice versus public good. Because even as we assert that the response to the pandemic cannot be about individual rights, we must acknowledge that there are those whose rights have been consistently trampled, or whose presence has been ignored, or whose needs are traditionally overlooked. And we are required to allow the rights of these underserved people to be proclaimed at this moment. Globalization and renewed attention to the way our institutions have failed to assiduously protect the rights of certain populations has begun shifting our conceptions of what the community is or what the whole means. This is a process that drives changes to ethical norms. Who has the right to the vaccine? Who needs the vaccine? When and in what order? And above all, why? Why are we doing things the way that we do? What vision of society are we upholding? We have to be able to articulate the procedures by which decisions regarding the public good are made and what the moral standards that drive our policies are. And this is precisely why I'm so grateful for today's symposium. This work is crucial to our future together. After a year's worth of divisive, unnecessary, and ultimately tragic partisanship, at least in the US, I'm heartened to see the current determination to tackle the complex problems we face collectively on a global level to advance the common good. That is something we strive to do every day at Columbia's Global Centers. Our mission is to promote and facilitate international collaborations, new research projects, innovative academic programming, and important global conversations such as this. For us, cross-cultural engagement is not limited simply to academic exchanges. We place equal emphasis on engaging with and learning fully from the world, which is why I'm delighted to report that among the several thousand guests joining us today, we have students and faculty and members of our global audiences from our global centers here in Amman, Beijing, Istanbul, Mumbai, Nairobi, Paris, Rio de Janeiro, Santiago, and Tunis, and from an additional 9 pop-ups we created to serve our international students during the pandemic. Today's proceedings will be moderated by my friend and colleague, Dr. Wilmot James, Senior Research Scholar at Columbia University's Institute for Social and Economic Research and Policy. Wilmot is a highly regarded member of our social sciences faculty, where he teaches a course on one of the most timely and relevant academic topics of our time, catastrophic risk. An academic by background with a PhD from the University of Wisconsin at Madison, Dr. James was previously a member of South Africa's parliament and Shadow Minister of Health. Dr. James is the author or editor of 17 books on topics ranging from public policy in South Africa to increasing public understanding of science to editing a collection of Nelson Mandela's presidential speeches. Wilmot, I turn it over to you.
So thank you very much, Safwan. Colleagues, I never thought I would live at a time when our lived environment in all of its dimensions, whether it's biological, economic, social, and political, would be remade by a microscopic viral agent whose only function in life is to search for opportunities to make copies of itself, hijacking our cellular machinery and outwitting through natural selection our body's defenses, enhanced as it is by rapid advances in modern medicine and biotechnology. In a pre-recorded interview with Meg Tirrell, conducted yesterday, I have the great pleasure of introducing Melinda Gates, who will address some of the key personal, social, economic, ethical, and governance and related leadership issues closest to her heart in the remaking of the world to which we all in our personal lives bear witness. Struggle with heartbreaking loss in our families scattered across the globe, trying to cope as best we can to summon the courage and to mobilize our endurance to do the right thing for all and not just for some, with the hope that vaccines will alter our journey to recovery dramatically for the better. Melinda Gates requires no introduction, but to say that she's a philanthropist, a businesswoman, and a global advocate for women and girls. As the co-chair of the Bill and Melinda Gates Foundation, Melinda Gates sets a direction and the priorities of the world's largest philanthropy. The foundation she has co-led has made a strong contribution to advancing global health, as it is making a monumental contribution to fighting the COVID-19 pandemic by smartly investing in the gaps in pandemic response, in mitigation, detection, and looking at our prevention systems. Melinda Gates will be interviewed by Meg Tirrell, who is the CNBC Senior Health and Science reporter. Meg Tirrell holds a bachelor's degree in English and music from Wellesley College and an MA in journalism from Northwestern University. Since joining the CNBC in April of 2014, Meg Tirrell has covered the development of new medicines for Alzheimer's, cancer, as well as rare diseases. And she has tracked public health emergencies from Ebola to Zika to the current COVID-19 pandemic. I now ask for the interview to be please screened.
Well, Dr. James, thank you so much. And I'm very happy to get to be here with Melinda Gates to talk about access to vaccines and the impact of this pandemic around the world. And Melinda, maybe let's start out by kind of looking at the moment that we're in right now. You know, sitting here in the United States, it's a very hopeful time. We are seeing numbers coming down of cases, hospitalizations, and deaths. We're seeing numbers going up of the number of people vaccinated. But we know that if we just protect ourselves here in the U.S., this pandemic is going to stretch on and on. I wonder what your reflections are, just seeing how vaccines are getting distributed and accessed. Is it essentially as you expected? What does this look like to you?
Yeah, thanks, Meg, for the question. I think we're certainly at a hopeful moment here in the United States. Even in my own backyard here in Seattle, I'm hearing of far more people's parents getting vaccinated after our healthcare workers. People are feeling hopeful that, oh my gosh, a vaccine may come to me in the next, 2 or 3 months. So you're hearing that hope. And we, as you said, we are absolutely seeing it in the declining numbers of hospitalizations and deaths. And yet at the same time, the work that Bill and I do around the globe and that my email inbox is filled with every day is about low and middle income countries. And this unequal distribution of vaccines, we are starting to see that begin to play out. And so, when you see a country like Israel, where 70% of their population is vaccinated, the numbers have come down drastically. But then I know that so many of the places I've traveled to, like Senegal or Kenya or Burkina Faso, they just, only 1 in 1,000 people there have vaccine yet. We know this unequal distribution is going to have a profound effect around the globe.
And given what we've seen in previous health emergencies, was the situation that we're in right now expected?
Well, yes and no. I mean, the sense that, look, we've never as a world created a vaccine this quickly. I mean, to see the scientific community come together the way it has, to share data, to share information, to work so robustly on vaccine candidates, that is amazing. And that they are vaccines that are safe and efficacious. I mean, a vaccine that's 94, 95% efficacious, that's an amazing vaccine. So that's unprecedented. But then on the other side of that is the distribution. And we have known as a world that distribution is hard. We've always known that. But you're seeing some places plan better for distribution than others. India, for instance, even though they had no vaccine this past summer, they did a massive planning and organizational plan so that when they got vaccine, they could distribute it and start to distribute it equitably. That's the kind of planning that needs to take place. And even the lumpiness you see in the vaccine distribution here in the United States, that's because of not great planning by the previous administration. Luckily, we are starting to see many countries in Africa beginning to plan for a vaccine, but that's exactly what's needed so that as supply becomes available, they are ready to distribute it.
And what do you expect in terms of that supply actually becoming available from what you see kind of lining up right now in terms of COVAX and what countries are talking about, rich countries like the United States or the UK, in terms of donating doses? I mean, here in the US, even by July, we already know we'll have enough doses for 400 million Americans. There aren't 400 million Americans, much less the number of people who A, are going to choose to get the vaccine, and B, we don't have a vaccine yet for kids. So we're just dramatically oversupplied here in the US. What does it look like for getting actual doses to other countries?
Well, there remains an enormous gap. And I think first we need to go back in history and remember 20 years ago, I remember when Bill and I first came into this vaccine work, I was shocked that when a vaccine came out in the United States or in Europe, it was taking 20 years to get out to these developing world countries. Now, as a world, we have closed that gap down to a year to 18 months. So that's incredible progress. But what COVID is showing us is we have not gotten far enough yet. A year, waiting for a year for a vaccine, if you're sitting in a low-income country, that is painful when you see the rest of the world getting it. And so we've got to shrink that gap down. One of the good things that you're seeing is the world came together for this COVAX facility. We just saw the G7 nations step forward and put more money into that facility. Last week, Germany stepped up with a big pledge. The US finally made a big pledge coming out of the December supplemental funding. Norway came forward with the pledge. That means COVAX will be able to buy more vaccinations, but it's still not enough, right? And so there's both the money issue and there's the supply issue. What you're starting to see the pharmaceutical companies work on is, can they do fractional dosing? Can we do just one dose? Can they get a vial that has more doses in it? As those innovations come along, we need to make sure, as there's extra vaccine or a country that has bought up extra supply, the United States or Europe, that we give our extra doses as fast and as quickly as we can to low and middle income countries, because this, COVID anywhere is COVID everywhere. And if we're going to have a full economic recovery, we have to get COVID cleaned up all over the world. It's both the right moral thing to do and it's the right economic thing to do.
Such an important point, and I wonder your thoughts on how messaging could be improved to remind us that it's not just the right thing to do, but the best thing to do for our own self-interest to make sure that healthcare workers in other countries are vaccinated soon. It just seems like, even though we talk about this a lot, we're still in an America First mindset here with vaccinating Americans first. And I want my vaccine dose, but it might not be in my best interest to get a vaccine dose before a healthcare worker somewhere else. I wonder if you think there are ways of effectively messaging that so that we could try to change these systems.
Well, I think people have finally woken up to the fact that we are a global community and our borders, these variants have come and are going to continue to come. We know that these viruses change and mutate. So, the UK variant is already in the United States. Probably the South African one is here. We're just, we don't surveil very much. So as variants break out, they will come to our own country and they're going to affect our health and the vaccines that are distributed here. So it's the right thing to do because it helps people stay alive in these countries. It helps their healthcare workers, and it means we don't have the variants inside of our own countries as well. So there's that argument that can be made, and it's not an esoteric one anymore. It's a real one. It's in our communities. When you see it and it's affecting us or our elderly parents, there's that argument. There's also the economic argument. If we want to reopen the travel industry fully, which benefits us so we can travel, but it benefits tourism. Kenya gets a lot of GDP off of tourism, as do many other countries. If you want to reopen travel fully, you want to have a robust manufacturing economy, we have to get global trade. The only way to get global trade up and running again is to make sure everybody participates in this vaccine. So I think those are some of the messages that I think will begin to resonate and are resonating for people.
Well, I wonder if you could talk a little bit about the role that different kinds of organizations can play here, from governments and what they should be doing, what you think they could be doing better, private industry, and also major philanthropies. How do those different segments kind of contribute to this bigger picture, and how should their response be different from one another?
Well, I'm glad you bring that up because, it is an ecosystem, right? It is the pharmaceutical companies and the medical companies coming up with vaccines and therapeutics and diagnostics. I mean, we need to have very wide scale testing to know where COVID is. There are things besides vaccines that if somebody gets sick, making sure there's oxygen available, making sure that some of the therapies are available, the medicines. So that is the role of private sector, is the innovations in those and putting the money in to do those innovations and sharing that information. The role of philanthropy is to make sure that everyone's included, that it's not just, high income countries and Europeans and the Japanese and the United States, that it is everybody. And we can show ways of doing that. We can help make sure that these vaccines are tested in different countries and in different settings that have a lot of HIV prevalence in a community. That's incredibly important. We can make sure that we help get oxygen supply and masks and tests to Africa. Philanthropists can do that. They can put money in. There's great mechanisms for that. And then government's role ultimately is to scale all of these things up massively, whether it's vaccines, whether it's therapeutics, whether it's diagnostics. That is government's role. And it is government writ large around the world. It's not only the WHO and contributing to that, it's all the country governments coming together saying, we care about a global response to this pandemic because it is a global pandemic that's happening. It's not just in a few countries, select countries around the world.
And I wonder, as you sort of lay out the roles of each of those players, what do you see going right when it comes to those? And what do you think could be done better?
Well, I think one of the things that was done right last spring, and it was, again, unbelievable to see it come together, is that governments came together and said, we want a multilateral approach and response to this. So things like the Act A accelerator came forward so that funding could go into a pooled mechanism for therapeutics and tools. COVAX came out of that as well, so that there was a pooled funding for vaccinations. I think that's an incredible thing that came together in a very short amount of time. It took a while for the funding to come in. The US was one of the last ones to come to the table with funding. So I don't think that went particularly well, but it's getting better over time. We still have a bit of a gap for sure in some of the funding there. Some of the things that have not gone well are these bilateral deals. Like, I understand completely, if I'm a low-income country, I want to know where I'm going to get vaccine. But cutting bilateral deals between, one country and two others, or one country and another, doesn't really help vaccine supply. We need to pool the vaccine supply so that we know we have an equitable distribution of vaccines. And so I think that piece is something that could have gone a lot better.
I wonder also your observations about the other important parts of this, access to medicines and therapies, oxygen, as you said, and also testing in a lot of low-income countries. What have you observed there that is working? And are there new concerns now with the variants? And also, is there any sense of complacency as we're getting so close to vaccines? Are you seeing testing declining? What are your observations there?
Well, we need far more testing around the globe, and we're going to continue to need testing because we are going to have pockets, even as we get this pandemic under control, we're going to have pockets that keep popping up, and you need to do very immediate testing and then isolation and quarantine. And so we need to get more tests out to the developing world. We need to have more surveillance labs in the developing world so we see the variants. We need better surveillance in the US to see when we get these variants, where they're coming up. So we need surveillance, we need better testing, and we need more rapid and large scale testing. So that is something still to be done around the globe. And again, I think we'll see some innovations coming in that space, but quite frankly, they can't come fast enough.
Yeah. Well, I want to ask you also, about another space that you've done a lot of work on. It's the impact of the pandemic on women, and it's just been an outsized one. Maybe just help us understand the scope of this problem, and then perhaps we can talk about what kinds of solutions you see and the good work being done.
Yeah, so I think so often the world for so long has seen this women's issue as a side issue or a nice to do issue. When we get around to it, we'll invest in women. No, what we're seeing with COVID is that women are dropping out of the labor force in droves. We've had 47 million women in 1 year drop out of the labor force. That's the size of the entire country of Spain. So what does that mean for us as a world? It means that when we start to recover, if we want a swift recovery, we have to figure out how do we get women back into the labor force, because when women are educated and when they're in the labor force, we have a much more robust economy in country after country after country. So this is a crisis. And we need to think of the solutions that will bring women back as the key building blocks, the infrastructure to a recovery. So there are really three things governments can do. They can look at this caregiving crisis we have. Women are doing 30 hours a week of caregiving. That's for an elderly parent, that's for a sick relative, that's for a child who's not in school. It's keeping her and knocking her out of the workforce. So there are solutions there. We have to prop up our childcare industries, which is being done, for instance, in East Africa. Finally, the Biden administration is going to do it here in the United States. So look at the caregiving crisis. Look at informal work. Most women around the world are working in the informal economy. And so they're the ones who lose their jobs first. The woman who has a vegetable stand, the hospitality worker, the service industry, those are jobs that are disappearing. And so there are ways to make sure that women come back into the informal sector by digitizing payments to them or relieving things like a utility bill, water, electricity. And then the last thing I would say, the third thing governments can do is make sure that women-led businesses continue to be funded. And governments around the world are seeing this, whether you're in Canada or Kenya or South Africa. You need to make sure we continue to fund women-led businesses so that those small businesses don't go away. They're some of the most fragile in the economy. Because again, you'll push both women's ideas and their labor force participation completely out of your economy.
And I wonder, you mentioned a number of solutions in there as well to what could help with this. Are people doing enough? Are governments doing enough right now on the childcare crisis, on upgrading digital payment systems? I mean, how much more can get done here?
Well, I think there's always more that can get done. Here in the United States, we're putting in $10 billion into the childcare sector under the new supplemental bill, but that's not nearly enough. We need $50 billion to support childcare. In East Africa, they're looking at how do they prop up their childcare sector so women and men have a safe, healthy place to put their child while they go off to work. The digital payments, India's done a fantastic job because they not only had a digital payment system, that is, you can get a bank account on your phone, they had data about women. So they made sure that the digital payments went to 200 million women. Why did they do that? They know that women spend the money differently. They spend it on their kids. They spend it on health. They spend it on things that prop up their families versus cigarettes or alcohol or flip-flops. So, we're seeing those digital payment systems, luckily, working and functioning in India, Nigeria, Indonesia, Kenya, Tanzania. But gosh, so much more is needed because people are in crisis around the world. People are going hungry.
Mm-hmm. And I wonder your thoughts. I mean, thinking about childcare, that also kind of stretches into the situation with schools and in-person learning. I mean, we have this here in the United States. We have realized through this pandemic how much we depend on schools for food, for security, for warmth. And we've just underinvested in all of those things and in schools, even realizing how important they are. I just wonder how you're seeing education kind of changing around the world as a result of the pandemic. And is this a moment where we could see a wake-up call to invest more in new systems?
I sure hope so. I think that, what COVID has done is expose the gaps that were already there in society, whether it was racial gaps and inequality, whether it was gaps for women, whether it's gaps for children. who in the United States has been most affected by the pandemic in terms of education? Low-income children, because they often don't have a laptop at home or access to good broadband. Now, you're seeing communities step up and libraries making sure that kids can come check out a laptop or a hotspot. But, so many kids are going to be set back in their education. If you're a high-income kid in the United States, you probably have access to digital tools, and you most likely, your teachers learned how by now to teach online. It's not the best form, but it's working. But that loss of learning is going to be huge. So we have to look at the flip side, which is the digital opportunity. It has taken off. We are doing seminars online. Kids are learning online. We're doing more Zoom calls as a world. So how do we take those digital tools and make sure that we tune them for low-income kids? We get them in their hands, but we help accelerate their learning and catch them up. We need to use that digital opportunity to do that. And I am seeing some good thinkers in this space working on this, but gosh, is there a lot of need?
Well, thinking about just technology upgrades and infrastructures all around the world, one thing we've had to do in the United States, and that I know is a concern as these mRNA vaccines reach developing countries, is the cold chain storage abilities. How big of a challenge is that around the world if, for example, we have leftover Pfizer vaccine and it needs to be stored at minus 94 degrees Fahrenheit, which I learned is colder than it is on Mars. Is that going to be a big problem?
Well, the mRNA vaccines, the extreme cold chain that they need is very difficult. So we know how to do cold chain in the most remote parts of the world. I mean, literally the last mile of cold chain for a polio vaccine, for instance, they take it in a little cooler and they put it on the back of a donkey or a motorbike, and it gets out to that remote rural clinic. So we do know as a world how to do cold chain, but this very, very cold chain is what's hard. Now, what's starting to look a little bit more promising on the mRNA vaccines is they might be able to be taken out of that super cold storage and last in a normal refrigerated environment longer. And if that becomes true, they will be easier to get out in the developing world. But here in the initial phase of this, if you're living in Johannesburg or Cape Town, sure, you could probably, if we get mRNA vaccine, you might be able to get access to it there. But some of the remote places out in, small villages in Lesotho or in Senegal, no, you just can't. A vaccine like that is just going to be very hard to deliver. And it's why our foundation has been quite invested in some of the other vaccines, the J&J or Novavax or AstraZeneca. And second, there'll even be a wave of vaccines that come behind this, a second generation of vaccines. And if we can look at a vaccine like J&J that's one shot and does not require cold chain, that is going to be much more easy to deliver in low and middle income countries.
And I wonder your thoughts, it's impossible to compare apples to apples, the efficacy we've seen from the mRNA vaccines whose trials were done, in the second half of 2020. We didn't have these variants as far as we know, versus the Johnson & Johnson vaccine, which showed a lower overall efficacy, but we know that there were lots of variants included in those trials. They ran a trial in South Africa. We assume there were probably lots of variants in the US, and maybe we'll get to see those data very soon about what contributed to that. But immediately there was kind of a reaction, oh, this might be a second tier vaccine, and because it's one shot and can be stored more easily, it'll be used more around the world. What do you think about that idea of are there tiers of vaccines, and is it an equity problem if the lower tier vaccines go to lower income countries?
Well, what I know is we need safe and efficacious tools for everybody. And so some of the vaccines, the ones that have 75% efficacy, that's actually still a fantastic vaccine. Mm-hmm. The tricky part are the variants that we know about and the ones to come. And so I think more trials need to be done, for instance, on the AstraZeneca vaccine to see, does it help tamp down severe disease? Because if it keeps somebody from not having to go to hospital to have oxygen or to be intubated, or they end up dying, and it stops the break in the disease there, so you don't go on to severe disease, that's still a really fantastic vaccine that should be used worldwide. And so those are the trials that now need to be run. thank goodness we're getting data out of these trials. All of these vaccines are going to have to be tested against the variants we know about today, the new variants coming. We know they will all have to likely be tuned over time. But then ultimately, it's up to the World Health Organization, like they have said with AstraZeneca, go ahead and use it. And then it's up to a health ministry in a country to say, do we want to use this inside of our population, depending on what variants we have and into what degree and scale. But what I know is we need lots of vaccines of many different types. And we not only need these first wave of vaccines, we need a second generation of vaccines, because we're going to be dealing with this pandemic still for a while.
Well, I'm curious to hear, in terms of the sort of second generation technologies, we hear about the current vaccine makers updating their vaccines to address the new variants. But I wonder also, are there new technologies that you're excited about that could come along in terms of a pan-coronavirus vaccine or a nasal spray, or things that you're looking at that are particularly exciting there?
Yes, we're always looking at that. Is there a vaccine that can cover multiple types of diseases? We're also looking at medications. Is there a universal medication that can help deal with different types of coronaviruses? So we are constantly working with the scientific community, investing in those kinds of tools, because that is going to be really important for no matter what comes along in the future. And so part of the $1.7 billion commitment Bill and I made was to really explore some of these different pieces. Like I said, these second generation vaccines, or even some of the first generation vaccines that might work better for low and middle income countries or more usable, because we're always trying to think the global community in mind, not just high income countries.
Well, I want to know also, you just mentioned polio, and it's so heartbreaking that this pandemic hit, and we've seen such a loss in progress in so many different areas. I wonder if you could just talk about what you've seen in vaccine coverage for other diseases, and the progress lost through the pandemic, and sort of your hope for picking that up whenever we can.
Yes. So when COVID-19 broke out, it set back global immunizations in an enormous way. It set back the poverty work. We'd been seeing many, many people not go into poverty over the last 20 years. We've seen a drop in the poverty rate, and now we see rising poverty, particularly for women. And so we see things like family planning. We think there will be 15 million more unexpected pregnancies this year because contraceptives aren't getting out there. Because we know in these weak and fragile health settings, the first thing that happens is people don't come in for services because they're worried, and the services start to break. And so this will be the systematic work that the global community will have to do to help build back health systems, to build back vaccinations. Luckily, the polio vaccine, the places where we still have polio in the world are Pakistan and Afghanistan. Luckily, the polio immunizations have now started back up en masse in Pakistan. And we're starting to see people return to health services. But there is so much work that needs to be done out there.
Well, we've just got a couple minutes left, and I wonder if we could sort of sum up. The question I love to ask people is, where do you think we are in terms of getting to the end of this pandemic? And of course, that really depends on what we do, but I'd love to hear your thoughts as to where we are sort of in this, if it's a baseball game, pandemic, and where we'll be afterwards. If you think that we will use this as a catalyst for improving our health systems and the way we approach public health.
Well, I certainly hope we use it for improving public health. I think, COVID has shown us, it's all literally right here in our face. It's in our own homes. Our kids are home. We're making sure our parents get their prescriptions. We're now out going to our jobs. We're working, if we're lucky enough, on Zoom so it's in our faces right now, and it's up to us as a world whether we build back and think about a future pandemic. And the reason I'm encouraged about that is when I think about coming out of World War II, what was built after that? We have had peace around the world. We have conflict zones and places that conflict has broken out. But as a globe, we've essentially had peace. And that's because, NATO came out of that. The United Nations came out of that. The WHO came out of that. So We need to build a pandemic preparedness system coming out of this so that as disease breaks out, which it will, we are there to go take care of it. There's an army of workers who can go in and immediately help do the surveillance, do the testing, take care of people, mop it up. So I'm not a huge baseball aficionado and by any means. I would definitely say we are not in the ninth inning. And sometimes, as you know, a baseball game goes beyond the ninth inning. I hope this doesn't go out beyond the ninth inning, but, we're probably at about maybe the fifth inning right now. We're starting to see countries like Israel or places like Scotland roll out mass vaccine, or places like the US, 10% of our population is vaccinated, but we still have a long way to go till we totally are at the bottom of the ninth.
Well, for somebody who's not a baseball fan, I think you handled that metaphor very well. Melinda Gates, thank you so much. This was a fascinating conversation and really important. We very much appreciate it.
Thanks for having me, Meg, and thanks for helping everybody think more about the whole global community and how we are all so connected. I really appreciate it.
Absolutely. And Dr. James, we'll send it back over to you.
Thank you very much to Meg Tirrell and to Melinda Gates. That was breathtaking. It was comprehensive. It was thoughtful, and it was from the heart. And so I certainly, listening to that conversation brings hope, but hope that ought to be delivered to the entire world, and that will take an enormous effort. So in the review, Melinda Gates made a number of key points I'd just like to highlight. The first is her remarks about mitigating and correcting the unequal distribution of vaccines in this world. A second point about ensuring that all players are involved in what she described as a health ecosystem that not only involves health institutions, but others. The great importance of advanced planning, the ability to anticipate what's required heading into the future, in particular with vaccine delivery, and making plans in advance that are adequate and rigorous. She emphasized the importance of better risk communication and messaging to reach audiences that are difficult sometimes to reach. The importance of having a fully financed vaccine facility so that we can see manufacturing and distribution in the world as a whole and do so on scale, together with better surveillance, better diagnostics, and better testing as outbreaks will continue into the future. The making of second and even third generation vaccines using the really advanced technology platforms that have been developed so quickly, in particular to deal with emerging variants, to have distribution systems built on technological innovations that can overcome cold chain challenges when it comes to the logistics of transportation and delivery during the last mile, mitigating and reversing the slowdown in current immunization programs, getting women back into the workforce by supporting childcare as well as geriatric programs, revitalizing the informal sector, as she described in Kenya, by having easily usable digital payment systems as a way of supporting women, especially working in small businesses in the informal sector. Investing heavily is really quite fundamentally important in online education for children across the globe, but particularly when it comes to low-income environments, and building a rapid response pandemic preparedness systems into the future. She made a number of other points as well, all quite important. It's now my pleasure to introduce to you our responding speakers and panelists from across sectors in the globe, starting off with Ames Dhai, who is based in Johannesburg, and Ames is a leading authority in bioethics, and she's based currently at the Faculty of Health Sciences at the University of the Witwatersrand in Johannesburg, as well as in the Office of the President of the Medical Research Council that's led by Glenda Gray. Ames can be credited with entrenching bioethics and human rights in the health sciences in South Africa, and in the name of Steve Biko, started the Steve Biko Bioethics Research Center at the University of Witwatersrand, in the light of the egregious violations of ethics committed during the murder of Steve Biko in South Africa. She also serves on a number of world bodies, in particular at the World Health Organization. Just as to say, she's not based at the WHO, but she certainly works in a consulting and advisory capacity at a high level, both at the WHO and UNESCO. So thanks again to Dr. Dhai, to Ames. Over to you.
Well, good morning, good afternoon, and good evening, everyone. I want to thank the organizers of this conference for inviting me to participate in this conference. I am sharing my screen, but it seems, oh yes, I've been able to make it move. Okay, so yeah, I'd like to thank you for inviting me to participate in this conference. There's a few things that I would like to cover in my response, but honestly, Melinda Gates and Meg are a hard act to follow. As we can see, here's the latest figures for Africa in terms of COVID-19, but I want to stress that these figures are not accurate, and they really are a large underestimate because testing is very far from adequate on our continent. We've seen disruptions, COVID-19 disruptions around the world. We've also seen the disruptions in Africa. Much of this has already been mentioned over the last 2 days and in the interview with Melinda Gates. But what I would like to stress is, in terms of the disruptions, Africa was already a very vulnerable continent. We've had multiple vulnerabilities, and these vulnerabilities, like corruption, refugee status, conflicts, civil wars, etc., have just increased the vulnerability of the peoples in our continent and in our continent as well. It's just been a massive increase in our vulnerabilities. So in terms of how we've actually worked towards approaching COVID-19 in Africa, we were fortunate that the African Union adopted a multilateral approach already early in February 2020. The AU started working at this, and the Africa CDC is one of the most active entities of the African Union. And for the purposes of today's talk, the Africa CDC, after undergoing a wide consultation with African leaders, stakeholders on the continent, put together a values framework for the fair, equitable, and timely allocation of the vaccines in Africa. This was a collaboration between Africa CDC and the South African Medical Research Council. What they did towards the values framework was they drew from African indigenous values and Ubuntu principles. The importance of community was emphasized in this framework. The interdependence and interrelatedness of people in Africa. And this, combined with the importance of community, was actually teased out to be to equate to the greater good for all while protecting vulnerable individuals and groups. And this was for vaccine access and hesitancy. The tradition of the African Lekgotla was brought into discussions, and this basically means that for generations, Africans have gathered under a tree to respectfully discuss issues and exhaust all options towards coming to consensus. And this was likened to meaningful community engagement in the vaccine discussions. So in terms of the framework, there were 4 values that were put together, and these are affirming the humanity of others, survival of the community, social solidarity, and meaningful community engagement. And all these values have had an impact on how the allocation decisions had to be made when looking at COVID-19 vaccines. And these values then answered critical questions on vaccine selection criteria, financing and procurement of vaccines, vaccine delivery, community engagement, communications, and research and evidence gathering. And I could discuss this further during the QA session. There's a lot that's been said about vaccine nationalism, but I felt I had to say something as well. And especially seeing that at the beginning, in South Africa and in Africa, many of us relied on COVAX. And it was really, really disheartening to see. And so disappointing to see that COVAX donators like the UK, the EU, and Canada undermining that pact that COVAX and the WHO was trying to bring forward in terms of equitable global access for vaccines for all. You know, one begs to find an answer to the question of what is it that is so hard to understand about no one is safe until everyone is safe? So we've seen this before many times. By November, look at all the countries that had pre-ordered. Yes, these countries were involved in vaccine nationalism. And when I saw that, except for Egypt, there was no other country there, and South Africa didn't feature, it was great. We're not actually undermining the COVAX deal. But Africa couldn't get left behind. And because of what the other countries were doing, the greed and the hoarding, the African Union and other countries in Africa then had to go forward and set up bilaterals. And, you know, when we look at the slide, for me, the inequities is so impactful. Here we have the United States, 331 million population-wise. Look at how much they've ordered in terms of vaccines. And here we have our African Union, 670 million, but is going to add to that to make it 750. So we could get the so-called herd immunity to cover, and 60% of our populations would be immunized. And early on, we can see this is early February, the countries that had already started the vaccinations, no one in Africa there. So what did this vaccine nationalism, this inequitable distribution mean to us in Africa? A lot of pain. We watched our healthcare workers die. And Meg actually alluded to this, where she talked about, should she be receiving a vaccine when healthcare workers in poorer countries are not receiving the vaccine? But this has been a really painful experience and lived experience for us. So in December, South Africa was in its surge, the second surge. And we had our healthcare workers extremely ill, close on to 6,000 healthcare workers being ill, and about 600 already dying. So South Africa realized it couldn't wait for COVAX and went ahead and ordered vaccines from India. And we received our AstraZeneca vaccines on the 1st of February. But unfortunately, a week later, our scientists informed us that the vaccine was not efficacious or had very little efficacy against our virus variant. And this variant was the predominant variant in the test. In about 98% of our tests showed that there was this variant. So needless to say, there was huge disappointment again, but our researchers and others to the rescue. So the president of the MRC, our health minister, together with Janssen Pharmaceuticals got together. And they really moved fast to get the J&J vaccines across to us, so we would not lose out on the plans that we'd already made for rolling out of vaccines to our healthcare workers. And they started 2 days late, but we're on a very successful vaccine program under the guise of implementation research. There are other issues that we've had down south and made worse by the AstraZeneca vaccine disappointment, and that is the problem of vaccine hesitancy. And this is something that we definitely are working on in terms of overcoming. And just this evening, the ministerial advisory committees have for COVID-19 have started putting plans together to have a technical working group at that level to address the issue of vaccine hesitancy. Today, at 1 o'clock Paris time, UNESCO launched its joint commission's call for global vaccine equity and solidarity, and just some pertinent aspects. We've heard about the financial issues, but UNESCO has also stressed that even if the financial bottlenecks are resolved, we must ensure that the shortcomings in infrastructure and logistics in terms of vaccine deployment and distribution are attended to as well. Otherwise, we're never going to reach that equitable access to vaccines. And it's also sounded a cautionary note to COVAX and cautioned it not to breed discrimination, because when you look at how we've bought into COVAX, you could either go into the optional basket where the country could choose the vaccine it wanted, or you'd go into a committed basket, which was cheaper than the optional basket. And because we couldn't afford in South Africa, we went to the committed basket. So we will only get the vaccine that COVAX gives us. And so there has been a caution that this should not result in first-class vaccines and second-class vaccines, depending on your financial situation as a country. UNESCO has also brought on the issues of the TRIPS agreement and has commented on the fact that the TRIPS and the World Trade Organization, some of their agreements were not designed to manage situations as the pandemic, and has recommended strongly that the use of the Doha Declaration is used to try to ensure that there is vaccine access to everyone. It's also pointed out that the business model of vaccine production actually needs to be relooked, and pharmaceutical industries should actually invest in facilities for vaccine production. Very important. Health is a common a global common good. And if health is a global common good, then the vaccines are a global public good. And I think this cannot be underscored enough. So the Lancet COVID-19 Commission in February, earlier on this month, also put out a statement where they were concerned with intellectual property rights and strongly recommended the TRIPS waiver in terms of IP. So there could be rapid scale up of production and distribution of vaccines and therapeutics, but it didn't stop there. It went further to say there should be accompanying transfer of technological knowledge and also assistance with production for these countries. You know, it's useless just giving a waiver of IP, but it's important that this waiver of IP must be added into a basket of other assistance to help countries develop their own capacity. And with that, I thank you for your attention.
Thank you very much to Dr. Dhai, to Ames, for a very, very, very thorough walk through some of the key issues that confronts the world of the South and highlighting what happened in the case of South Africa. She in particular paid special attention to the big ethical challenge when it comes to medical and therapeutic rationing, and highlighted the fact that the framework to be used for distribution, the model for distribution, has to rest on the pillars of public health and the pillars of moral values and of community anchors when it comes to understanding issues of justice and access. So thank you very much for that. She touched on and just highlighted the issue of conducting research during a unfolding pandemic, and we'll pick up on that issue in the conversation. If I can now turn to Dr. Ruth Faden and to introduce her to you as the founder of the Johns Hopkins Berman Institute of Bioethics, serving as its both founding director from 1995 to 2016. She currently works on ethical challenge in biomedical science with a particular focus on women's health and the rights and interests of pregnant women. Currently, Ruth is working at the intersection between structural justice and the COVID-19 response, primarily in vaccine allocation and the prioritization and K-12 education challenges when it comes to children. Thank you very much, Ruth, for joining us, and over to you.
Thank you, it's a pleasure. Thank you, Dr. James and the other organizers of this amazing symposium. It's truly an honor to be part of it. Much of what I want to say has in many ways already been said, and perhaps far more authoritatively than I could have yesterday by Dr. Tedros and by Nikki Lurie and Jeff Sachs, and just a moment ago so eloquently by Ames Dhai. I'm going to say some of the same things, but from a slightly different, very intentional formal ethics and equity frame. So in a structurally just world, vaccine would be allocated to all people, regardless of where they live, according to some morally defensible set of criteria, perhaps something along the lines of what is put forward in the WHO SAGE values framework and prioritization roadmap that Dr. Ruiz Matus referenced on Monday, during the Monday part of the symposium. So we'd have some agreed to values framework for allocating vaccines globally, fairly to all people of the world if we lived in a structurally just world. But of course, the world we live in is very far from a structurally just world. We live in a world of profound differentials in wealth and in geopolitical and economic power between high income and middle income and low income countries. This is a world in which high income countries engage in negotiations with other states, with supranational global institutions and with global corporations from a profoundly advantaging bargaining position relative to poorer countries. It's a world in which the countries of the North that I'm supposedly standing in to speak about, if not for, regularly, if not almost all the time, in the name of self-interest, act in ways that perpetuate and exacerbate patterns of global domination, exclusion, and exploitation. So that's the world we live in. Not all the time, not about all things, but basically much of the time. And I did hope that given this pandemic and the magnitude of this pandemic, things might have gone differently this time. It has never before, in terms of a global response to a crisis or emergency, but I was hoping this time it would, and I was especially hopeful and remain hopeful about the model that the Act A and the COVAX facility represent. And it should be marked today, of course, that this is the day that the first shipment of doses from COVAX, I believe, have been sent to the first countries in Africa, to Ghana in particular, a very important thing to mark. So I started very hopeful, but for me in the end, at least to this point, the pandemic has been marked by an absolutely shocking failure on the part of the world's wealthy countries to live up to even a minimal understanding of their obligations in global justice to the world's poor. And I say obligations in global justice advisedly. I don't mean charity. I don't even mean humanitarian obligations. I mean the obligations of wealthy countries as a matter of justice to the rest of the world. Now, yesterday, Nikki Lurie spoke eloquently about vaccine nationalism, and Ames as well, just a few minutes ago. For a moment, I want to bracket the term vaccine nationalism and introduce a somewhat different term, vaccine partiality. Countries being partial to the interests of their own citizens is not only politically inevitable in the current global order, it is ethically justifiable. Indeed, it is ethically obligatory. There's nothing I'm going to say now that everyone participating on this panel and listening doesn't know, but I think it sets the frame for how we should be thinking about what is going so very wrong in the world today. States do have, in our current global order, the first line responsibility to protect and fulfill the human rights of their citizens and to promote their well-being. Indeed, a state's claim to political legitimacy rests in part on its meeting this responsibility to its citizens. In the context of a pandemic, securing vaccine for its citizens surely falls under this obligation. And thus, vaccine partiality on the part of nations is ethically justifiable. But that is not the end of the story. The global order that places states in this special relation with respect to the well-being and human rights of their citizens results in enormous gaps in human rights protections and enormous deprivation for millions upon millions upon millions of people. Wealthy nations have a moral responsibility to address the impediments to human rights fulfillment that flow from the differentials of interstate and global institutional power from which these wealthy states benefit. These differentials are what allow them to so successfully advance the interests of their people on the global stage. However, wealthy nations are not entitled to pursue these interests with complete disregard for their impact on other peoples of the world. Now, there's no agreement about where the line falls. That is to say, there's no agreement about how to strike a balance between justifiable vaccine national partiality and global obligation for equitable vaccine distribution. But at minimum, I mean, sort of put this out there as a minimum obligation, wealthy countries should not pursue national advantage in the global vaccine marketplace, when doing so makes it extremely difficult, if not nearly impossible, for other countries to provide protection against severe deprivation for their citizens in the context of a global emergency. But as we've heard yesterday and continue to hear today, that is exactly what is happening. Many wealthy countries of the world have exactly been doing this. They have been stepping in front of COVAX, undermining its contracts. They have cleared the shelves, as one journalist put it, a vaccine before other countries could even go shopping. And they've secured, as Ames has shown so compellingly in her slides, many-fold more vaccine than they could possibly use. Wealthy countries have hoarded raw materials and failed to share technology, and they have kept the prices that they are paying for vaccine secret in many contexts. And perhaps most importantly, they have failed to come up with anything like the amount of funding that is needed to get even close to global equity in access to vaccines. There are increasing calls for wealthy countries to redirect vaccine supplies that they control to COVAX or directly to low and middle income countries as one way for wealthy countries to balance justifiable vaccine national partiality with global obligations. Again, the challenge is, where should this moral line be drawn? We just had listened to a very quick sort of reference back and forth between Ames and the interview with Melinda Gates about this, painful recognition that there is a prospect that young and healthy people will be vaccinated in wealthy parts of the world before the most at-risk health workers in some of the world's poorest regions of the world, not South Africa, fortunately, but other places, will even see a vaccine. And there have been some proposals that wealthy countries should vaccinate, after having vaccinated their health workers and their oldest adults, that vaccine then be redirected to COVAX at that point. Now, it's my view that that kind of proposal is not only politically untenable, it's also, frankly, ethically not particularly justifiable. That is to tell countries that what they ought to do is redirect vaccine as soon as they've covered their healthcare workers and their oldest adults. And that's because of the impact of this pandemic on every aspect of well-being. It's not just about preventing people who are at greatest risk of severe disease and death from becoming severely ill and dying. It's also, importantly, about using vaccine to protect the interests that all of us have in returning to a place where we can live our lives more fully. And this is particularly of concern with respect to children. And I don't have the time to go through this now, but I hope in discussion we will talk about the special impact that this pandemic is having on children worldwide, and that Melinda Gates referenced with respect to the disruption of global education. Now, I don't mean to suggest that it is inappropriate for there to be redirection of vaccine from wealthy countries to low and middle income countries now. It is appropriate. The question is the pacing and how it should be done. And I think we should look potentially to Finland as a model where the process for redirection of vaccine that's under the control of a wealthy country is being considered, and where it's being considered at a pace which can be viewed as still meeting the human rights obligations of the country to its own citizens. And I also don't want to suggest that redirection of vaccine is not important. It is very important, especially as Ames has illustrated, when some countries have such a disproportionate amount of vaccine under their control. But it's also very important to recognize that the solution is not in the redirection of vaccine alone, or even primarily. We really have to see wealthy countries step up, eliminate the obstacles that they have put in the pathway of access to vaccine for the rest of the world. And most importantly, we need to grow the vaccine pie. We need to increase the supply. We have to address the TRIPS obstacles that Ames has introduced. We have to share this technology. We have to deal with price affordability and transparency, and we have to see the investing of real money of the sort that Jeff Sachs was suggesting yesterday. If the wealthy countries of the world fail to do so, history will judge the global North harshly for our abject moral failure to meet even a minimal understanding of what global justice and a commitment to universal human rights requires in a pandemic. Now, I have been framing these issues intentionally and entirely in terms of ethics and equity, but I have no illusions about the likelihood that any arguments grounded in global equity and justice appeals will alone be persuasive. Fortunately, as we all know, and as we have heard so eloquently already in this meeting, there are powerful self-interested reasons as well, matters of national security, national economic recovery, geopolitics, and soft diplomacy that may still move wealthy countries to change their current conduct beyond even the welcome expressions and commitments that were made at the G7 recently and from the US in particular. Whatever the motivation, there is still time to make a difference in this pandemic. And whatever happens in this pandemic, there will remain an absolute moral imperative to develop the global institutional structures and systems necessary to come far closer in the next pandemic to global equity in the world's response. Thanks.
Thank you very, very much to Dr. Faden, to Ruth for her contribution and on elaborating in some detail issues to do with vaccine nationalism, vaccine rationing, and what the ethical framework ought to be, and why we must embrace, for both public health reasons and also for justice reasons, a system of fair allocation. She raised a number of other issues of great importance as well. And one we will pursue in the conversation, Ruth, dealing with children in particular. So I'd like us to pursue that in the discussion. So if I can now turn to Mukesh Chawla, and Mukesh has been involved for 20 years with governments and international development partners based at the World Bank. He's the coordinator of the Pandemic Emergency Financing Facility at the World Bank and has served as an advisor when it comes to issues of health, nutrition, and population. His current areas of interest, which is so directly pertinent right now, and responsibilities to help countries get better prepared to respond immediately and effectively to disease outbreaks that have the potential of assuming pandemic proportions. So thank you again, Dr. Chawla, for joining us. We really value your contribution, and over to you.
Thank you. Thanks a lot, Wilmot. And thank you to the organizers for giving me this opportunity. Though I must complain that it's awfully difficult to speak after Ames and Ruth, but I'll give it a shot nevertheless. You asked me, Wilmot, to speak a little bit about what the World Bank is doing in the world of vaccines, both trying to ensure equitable distribution of vaccines and urgent and effective distribution as well. As we all know, the equitable distribution of vaccines depends upon several factors. I'll just list a few of them which we think are important. One, that there is availability of supply so that it can be made available. Second, that is distributed to all the countries and populations that need them. Third, that countries have effective systems for deployment of those vaccines. We heard earlier about cold chain and other issues that can come into play. Clearly, providing fair and equitable access to vaccines will be key to managing the health and economic repercussions of the COVID-19 pandemic, because the COVID-19 still has an extremely important bearing on the economic outlook. And we need to make sure that all of the challenges that are associated with the rollout of the vaccine are, to the extent possible, mitigated and addressed. And the challenges are many. The supply itself, the supplies are limited. We have seen that in almost all of the countries in the world, including the richer countries. The supplies are picking up. We expect that in the months to come, there will be many, many more vaccines which will be in play, which would significantly increase the number of vaccines, the amount of doses that we have available for distribution. Countries, however, would need to have access to these vaccines, and Ruth and Ames have spoken about those issues already, and I will not dwell on that. The only thing which I will mention here is one of the essentials, over and above the various issues that have been covered by Ruth and Ames. One of the issues which we believe is extremely important, that countries need to have money, or somebody needs to have the money to make sure that those vaccines can be purchased from the suppliers. The World Bank has made available $12 billion, has created a facility, a fast-track facility for vaccines finance. And at this point of time, a very large number of countries have come forward. Almost on a daily basis, we are working with countries to fast track their applications and their projects to make sure that financing is not a constraint to the supply of vaccines. There may be other issues, but we don't want financing to be a constraint. This financing goes to countries. Countries can use that financing bilaterally in their discussions with the suppliers. Countries can use that in their conversations with COVAX. Countries can use that in whichever format that makes most sense, as long as the vaccines which are being procured are quality vaccines and and are approved by the known international standards. The second part of ensuring equitable distribution of vaccines is making sure that countries have the capability of deploying those vaccines. Well, this is not something new. Countries have been working with vaccines now for a very large number of years. But the sheer scale of this exercise, the target population, the adult population, the sheer numbers, that is what confounds the scene a little bit. What we are finding is that a large number of countries have tremendous amount of experience, particularly in distributing vaccines for children. But if you look at the scale of that distribution and the time frame that you get for that distribution compared to the scale of the COVID-19 vaccine distribution and the time frame that you have for this, then you will see the stark difference that what we are talking about just now is an unprecedented challenge. The way that we see it is that this is perhaps the single most important public health challenge to distribute so many vaccines. We're talking of billions and billions of doses, 2 doses per person. If we have to do even 50% of the world's population, we are looking at 7-8 billion doses of vaccine, and distributing those 7 billion doses of vaccine extremely rapidly. For that, you need to have a system in place. You need to have the vaccinators in place. You need to have the safety surveillance mechanisms in place. You need to have the cold chain. Why the cold chain? The entire supply chain from the time that the vaccines land in the country. What happens? What happens at the airport? The vaccines are in for example, the belly of the passenger aircraft. How do they come out from there? Where do they go? To which point of distribution? How are they then stored? How are they then transferred from the big pallets in which the whole distribution starts to the smaller containers to the point of dispensation? So this whole journey from factory to the syringe to the arm that involves so many different players and so many different aspects of coordination and logistics, that is a huge challenge. So a few months back, I think it was in November sometime, that together working very closely with WHO, UNICEF, Gavi, with other partners, we launched the goal of getting to 100 countries in 100 days, making sure that 100 countries are ready to deploy the vaccines in 100 days. And I'm very happy to say that as we speak at this point of time, at least at some minimum, more than just a minimum level actually, more than 100 countries, I'm talking about the low-income countries, at this point of time, are ready to start deploying the vaccines. Today is a momentous day, February 24th, and we shall remember this day for some time. Today is a day when the first of the COVAX vaccines, the first lot of COVAX vaccines, 600,000 doses, reached Ghana early in the morning. And that is just the beginning. What we have found is in most countries, we do not have, so when we started this work, we thought that one of the biggest challenges would be cold chain. But happily, what we are noting is that in most countries, cold chain is not a problem for vaccines that need to be stored at negative 20 degrees Celsius or up. Yes, those that need to be stored at temperatures lower than negative 20 degrees, that's a whole different ballgame. But negative 20 and up, most countries over the last 15, 20 years, thanks to Gavi, thanks to the funding from the Bill and Melinda Gates Foundation, thanks to other initiatives, have been able to build up their cold chain. But of course, these cold chains are only enough to handle small quantities of vaccine which were required at that point of time for children. But to scale it up all of a sudden to huge quantities, yes, that is going to cause a jam in the entire supply chain. And we are working very closely with our partners on the ground, Gavi, UNICEF, WHO, others, to make sure that the flow of vaccines happens to the extent possible seamlessly. It's not an easy exercise, as you can imagine. Even in the most organized countries, the richest of countries, we have seen all sorts of glitches in this flow, and we expect this to continue, and we expect that there will be issues, but the countries will keep on learning as they go along. All in all, at this point of time, as we speak, 24th of February, remain extremely optimistic. Further 2 million doses from COVAX are supposed to go out in this month of February in the next few days. A further 4 million doses should be available in the month of March, and it is going to exponentially increase. And we are extremely optimistic that we should be able to start targeting at least our healthcare workers, our frontline workers, the elderly population in most of the low-income countries, the vulnerable population, people with comorbidities as soon as possible. So it's a journey, which we started on this journey a few months back. Today is one of the watershed moments, and there will be many, many more. There will be glitches, that's the reality. There will be moments when we will wonder and will get overwhelmed by the enormity of this operation. But as we sit here today, we feel pretty confident that we should be able to get there. Back to you, Wilmot.
Thank you very much, Mukesh. Really value that. And as I was listening to you and you telling the story just from the financing side, I became more and more hopeful. And what would be very good is to be able to communicate that message to the globe in terms of vaccine distribution when they get into their destinations, in the time that they are. So thank you very much for the walkthrough, the financing side, and elaborating on the World Bank. It's now my great pleasure to introduce to you Peter Hotez, who is the Dean of the National School of Tropical Medicine and a Professor of Pediatrics and Molecular Virology and Microbiology at the Baylor College of Medicine, where he's also the director of the Texas Children's Center for Vaccine Development and the Texas Hospital Endowed Chair of Tropical Pediatrics. They say that you can quickly spot a pediatrician because they wear a bow tie, because if they wear a tie normally and they treat children, the kids tend to pull at it. So very welcome to you, Peter. He has led national efforts to defend vaccines, which has brought him into a lot of trouble, and to serve as an ardent champion of vaccines, a very, very important function. In 2019, Peter received an award for leadership in advocacy on vaccines from the American Society of Tropical Medicine and Hygiene. So Peter, we're now at 1:32, just at 1:30. I want us to have 15 minutes for discussion with a focus on kids in particular. So over to you.
Great, thank you so much, Professor. It's an honor to be here. I won't go on too long. I'll just make a couple of remarks. I wear two hats. I'm a vaccine scientist, and we've developed our own low-cost recombinant protein COVID vaccine that's now being scaled to 1 billion doses in India, maybe the first people's vaccine for COVID-19, as they call it. So I'll talk about that in the context of equity for a few minutes, and then my other hat, which has been for years going up against the anti-vaccine movement, being targeted by them because I have a daughter with autism and wrote a book a few years ago called Vaccines Did Not Cause Rachel's Autism, about my daughter and where I see the anti-vaccine movement heading. So with point number one, I'm really concerned about the world's low and middle income countries, because one by one, our options are evaporating. It looks more or less, and I'd be curious what Dr. Chawla has to say about this, but I'm concerned that the mRNA vaccines are not going to have a very big role in global health anytime soon, at least beyond U.S. and Europe. The difficulty in scaling them up and the complexity of the freezer chain requirements. Eventually, for RNA vaccines, we will figure this out. 5 years from now, I think we'll have the technology will have matured to scale up production and maybe even to keep it at room temperature or simple refrigeration, but not now. So I don't think the mRNA vaccines are going to have a big role. Then you have the fact that a lot of the big players have either dropped out or are seriously delayed. Merck and Company is out. GSK and Sanofi are significantly delayed. It's unclear what role they're going to have anytime soon. And then we have vaccines of substandard quality that have bypassed national regulatory authorities coming out of Russia and China. So it's unclear how effective they're going to be, certainly against the variants, because they give very low levels of virus neutralizing antibody to begin with. So when you start, one by one, they start dropping out. And when you look at what's standing, there's actually not a heck of a lot out there. There's the AstraZeneca Oxford vaccine, of course, which is a good vaccine for the original strain and the UK strain. It's looking like it may not have much impact on the South African strain that's now starting to take over. It's in South Africa. It's expanding into Zimbabwe and elsewhere. So how helpful the AstraZeneca vaccine in its current form will be for Africa is an unknown. We have the Johnson & Johnson vaccine, which I think will do a lot of the workhorse. And then you have our recombinant protein vaccine that's being scaled to 1 billion doses in India. This is a same technology as the hepatitis B vaccine. It uses a yeast fermentation technology, and it's been, which has been gone into kids for almost 40 years. So I have some hopes that this would also be useful as a pediatric vaccine. There are a couple of other recombinant protein vaccines that are out there, but we don't have much. And, how did we get to that state? I think everyone was well-intentioned with COVAX and the sharing facility. I think, if I had to point to one thing to do over again, a lot of the initial funding was focused on innovation. It was all about innovation, and innovation's important. But at the end of the day, you do need some old school vaccines. And for our vaccine, we'd been making coronavirus vaccines for a decade. And for our COVID-19 vaccines, ultimately to get started, I needed to raise $1 million from Tito's Vodka. So if you're going to have a vodka drink tonight, it should be using Tito's Vodka. $1 million from the Clayburgh Foundation, the JPB Foundation. Now, later on, now that BioE is scaling this up, CEPI is now coming in. But, at the end of the day, to solve the world's global problems, we had to rely on Tito's Vodka and other foundations in Texas. There's a problem there, and maybe we can discuss it. I think the other piece to this is this rising anti-vaccine movement, which I think we've allowed to get out of hand. It really started accelerating around 2015. I think the benchmark, the 1998 paper in the Lancet by Andrew Wakefield and his colleagues, but it really revved up in the US around 2015 when it linked to political extremism on the far right. And it came out where I live and work in Texas. It's when Texans for Vaccine Choice started, Oklahomans for Vaccine Choice, very much linked to libertarian concepts of health freedom or medical freedom. But then it rapidly expanded across the country. They began targeting specific ethnic groups like the Somali immigrant community, the Orthodox Jewish community, and now the African American community in Harlem, holding a series of anti-vaccine rallies at the Riverside Church in New York, right near the Columbia campus. And so this is causing a lot of damage. And then last year, with COVID-19, that what was an anti-vaccine movement expanded its remit to protest against masks and social distancing. So it became a full-on anti-science movement. And this then migrated to Western European capitals. So all last summer in Trafalgar Square in London, in Paris, in Berlin, where they wound up storming the Reichstag, the German parliament, in Rome, they held anti-mask, anti-vaccine rallies, which New York Times and BBC reported were associated with QAnon. So that far right-wing extremism that was generated out of Texas became a globalized movement. And now, of course, the U.S. and British intelligence report that the Putin government and Russia has been piling on with this program that they call weaponized health communication. And so we've got now a problem on our hands with this full-on anti-science movement. And this is going to be around with us for a while until we get some appetite, I think, to start taking a hard look at this and potentially taking some of this down. So those are my two big thoughts. How we, through well-intentioned efforts, created a global sharing mechanism, but maybe leaned too heavily on innovation, not enough thought to simple, robust COVID-19 vaccines for low and middle income countries. And second, we still lack that resolve, that fortitude to start really taking a hard look at the anti-science empire.
So thank you very much to Dr. Hotez for his very quick but very insightful overview of two large questions. And so to follow on his remarks, I wanted to pursue at least three questions. The first one most immediately has to do with the question of, as you put it, the limited reach of mRNA vaccines as a platform and making traditional vaccines and get a response from Mukesh in particular, but from anybody else on that front. I'd like to pursue the question also of children and would like to ask Ruth Faden to respond to that. I'd like to also return to the question of how we push back against misinformation, Dr. Hotez. And so the issue of bringing women back into the workforce was raised by Melinda Gates as well. So those are four large questions requiring a lot of time, and we don't have a lot of time. So, but let me first of all start off with asking Mukesh to respond to Peter's comment about the limited reach of mRNA vaccines and what can be done to both on the manufacturing side, but also the distribution side of traditional vaccines.
Thank you. Thanks a lot, Wilmot, and thank you, Peter, for raising that point. I will not speak about the effectiveness of the different vaccines. You have covered that already. As far as the delivery itself is concerned, the distinguishing feature of the mRNA vaccines compared to, for example, the other vaccines that are much more of the kind of traditional adenovirus is the cold chain requirement. The cold chain requirement for one of the two mRNA vaccines, the Moderna, which is -20, most low-income countries have that capacity. Now, again, as I said earlier, they don't have that capacity at that large scale, but they have that capacity. if I'm getting the vaccines in smaller quantities, but in a regular manner, I should be able to push through the supply chain. The other one that requires -70, -80, you're absolutely right. Most countries do not have that capacity. The only way in which we can do that is what we had done in the case of DMC, for example, the Ebola. We had those, so those also had to be stored at -70, -80. We were able to transport that in the Arctic and put the Arctics on the back of a motorcycle and push it through. The scale there was much smaller, obviously. We are not talking about the same scale. So in certain geographies, particularly in urban geographies, particularly close to the port of landing, even those that even the Pfizer type vaccine, if, of course, assuming that we can actually get the supplies, we should be able to distribute in a very large number of. Will we be able to scale it up to get to the rural geographies? No, definitely not as far as -70, -80 is concerned in a short time period. Will we be able to scale that up for Moderna at -20? I think so. I think so. I think that in most countries, 7 or 8 countries where this can be a huge challenge, but in other countries, we probably would be able to. But again, a lot of logistics management has to happen there. It's not the cold chain that worries us so much, it is supply chain that worries us much more, because that includes because it's not the cold chain by itself, it's the people, it's managing at every stage, at every time to keep the time, temperature, or continuum balance. And that can be a huge, big challenge. On the supply of vaccines, again, our role here at the World Bank, and we are committed to that, is to make sure that financing is not a constraint to countries. And we will make sure that is not a constraint. The $12 billion facility, a fast-track facility, was announced 3 months back, well before even the and countries have been able to plan around that. I will stop here, and the challenges are real, as you rightly point out, Peter, and it will not be easy, it won't be smooth, but at least financing, we won't let financing be a constraint. Back to you, Wilmot.
Thank you very much, Mukesh. If I can turn to Ruth Faden, you feel free to comment on this particular issue, but I wanted you in particular to just pursue the line around the place of children in this pandemic and what is happening in terms of the actions being taken, both with regards to the lost time when it comes to education and what the plans are in motion for taking care of children's both health needs, but in particular, also their educational needs.
Thank you, Wilmot. I'll try to do this in short compass, and I'd be very eager for Ames or others to follow up on what is happening, for example, from Ames' point of view in South Africa. So the children need to be pulled out of this as we think about the impact of the pandemic, obviously not because they are at significant direct risk of severe disease and death, although the full picture there is not known, but because of the indirect impact on the well-being of children and the direct in terms of other causes of child burden of disease and death that is a consequence of what is happening to disruptive health services. And also, especially because of the impact of the pandemic on child development. It'll be a while before we appreciate what the disruption of schooling has meant for the well-being of all children. But as Melinda Gates pointed out, especially for the well-being of children who, before the pandemic, were already profoundly disadvantaged with respect, not only to their academic skills, but also to their physical health, their emotional health, and their physical security. So what we're seeing now are the beginnings of estimates to suggest that while all children have lost 9 months, a year, 12 months plus in terms of academic development. In some cases, it's more like 2 years. And what is particularly concerning is the beginnings of an indication that some children will never return back to school. That even where schools have been restored, there are much higher rates of absenteeism there, and this is global. There are children who are missing from the system, and a minute's reflection underscores why that is likely to be the case. When children were barely in school, whether it's in some parts of the world, girl children for whom education was just beginning to be seen as regularized, or for all children at pivotal points where continuing with education is questionable and people are thinking about workforce participation, you mess up schooling for them. And why would they, the forces that were barely getting them there now are undermined and they're not going to get back in. And let me just say one thing, and I'll stop with this. The impact of setbacks to interest to the well-being of children, and Dr. Hotez and others, as a pediatrician, I'm referencing you, but just generally, right? When you set back the interest in the well-being and the development of children in childhood, the implications are often lifelong. This is not a matter of, catching up, getting your arithmetic skills back up. This is much more profound than that. And that's one of the reasons why children need to be prioritized, not necessarily for vaccine, although that's an interesting conversation we could get to, but prioritized in terms of the responses that are just now being put into place.
So thank you very much for that, Ruth. If I could turn to Ames and to say that there are a number of issues that we couldn't get to, and we probably won't be able to get to, but on the question of children, Africa is a continent of young people. The loss of education for any child is awful, but it's particularly awful in Africa because of the scale of it and the fact that the infrastructure is not what it ought to be in order to genuinely talk about education online. If you can comment on that, I want to give Peter also the last word, and we are planning to close it at 2 p.m. So over to you, Ames.
Thanks, Wilmot. I can't agree with you more, and also with Ruth, in terms of the huge disruptions we've had with our schooling systems throughout the continent and the impact of this. But when we look at schooling in Africa, it's not just schooling for an education. It's also schooling so that the child could get that plate of food a day. So in terms of the food schemes as well, there's been huge problems. So, it's been a ripple effect in terms of nutritional status, etc. We've just had the results of our matric, that's the secondary schooling, released this week. Released late, supposed to be released in December, but it was released now, so we're 2 months behind. And what that showed was that there was a drop in the pass rate as compared to previous years. And also, in terms of the uptake with regard to exams, there was a huge dropout rate as well. So it's very similar to what you'd see throughout the world. But what I want to talk about is the fact that Melinda spoke about digital tools. Yes, in the ideal world. I don't know how that's going to work in Africa when we have such a huge digital divide. And maybe it's time we started looking at, we have various rights which are human rights. And so maybe we need to look at access to data as a human right as well. And perhaps go to the UN and make representations there to build this in as a human right for everyone in the world. Thanks. Over.
Okay. Now, thank you very much for that, Ames. I want to give the last word to Peter. He has a hard stop in 3 minutes. And I wanted to give us in 3 minutes what you believe the strategy would be to improve and enhance vaccine take-up as the vaccines are being rolled out in the world.
Yeah, and this was a fabulous panel, and I appreciate the attention to children. And I think, you know, one of the things that I see even in the U.S. or globally, we're trying to be everything to everybody. We want to save lives, reduce hospitalizations and deaths. I don't think anyone would argue against that. But we also want to interrupt virus transmission. We want to open up the economy, and we want to open schools. And the reality is, at least for 2021, we're not going to be able to do all of those things. And I think there has to be some level of priority setting. If you left it to me, I'd focus on saving lives and getting kids back in school and build vaccine strategies around that. But and so what you're getting instead is our elected leaders or leaders in general are trying to be everything to everybody, and it's being sort of muddled and confused in terms of what the actual goals are. I think in parallel, we do have to dismantle the anti-vaccine empire. It's actually not that hard to do. We just have to have the resolve, and we're not doing it in the U.S. I'd love to see an interagency task force at the UN to really look at this because it is globalizing. We're seeing how this affected measles in Samoa and the Philippines. We're starting to see how it's affecting Western Europe and then Eastern Europe and the Ukraine and Russia. So this isn't going away. It's going to be amplified.
Thank you very much, Peter. And I know you have to drop off. So I really would like to thank you for joining us, and we will be in touch for sure.
Thank you.
All right. Thanks so much. So colleagues, let me say that this has been absolutely wonderful. We covered a whole range of pertinent questions that broadly fall into the domain of ethics, into the domain of governance, into the domain of the effects that the pandemic has had on women, on children, and what the vaccine hope actually represents in taking us on a journey out of our current crisis. And I come out of this conversation feeling hopeful. If certain key things fall into place, but there is a need to accelerate what it is we're doing on a global scale in terms of vaccine rollout, and doing everything associated with making sure that people who must get access to it gets access to it. It's partly a technical problem. It's partly a technological problem. It's more of a political problem, in my view. To solve some big social issues around those questions of access raised by our current structure of inequality in the world. So I want to say that there are a number of things we did not get to. We did not discuss the whole question of conducting research during a pandemic. We didn't get to the question of how one goes about dealing with suspension of rights during an emergency, and the conduct of the police and the military, and the abuse of citizens during lockdowns and quarantines is a major question. We would have to leave all of those issues to a later time. I think we've covered the ground very well in as much as we can in the 2 hours. I'd like to thank, in order, Safwan Masri for really setting the tone for today, with these really quite broad-ranging remarks, and also to say that Safwan represents a number of things, but the one thing it does represent at Columbia is that the global centers are this university's global footprint. And he has made every effort to pull faculty members and students into that conversation from all across the world. So they'll be very grateful for that. In their absence, Melinda Gates and Meg Tirrell for the interview, and to our panelists, Ames Dhai, Ruth Faden, Mukesh Chawla, and Peter Hotez. I thank you very much for your contribution. As always, these sorts of conversations happen when they happen. This pandemic is not over by any means. We will talk again. And with that, we've got a slide on screen to thank the individuals who are not seen, but whose work and effort make everything possible in terms of having a smoothly function virtual a meeting like this. And so with that, if I can bid you farewell for now, and enjoy the rest of your evening or your afternoon or your morning, depending on where you are in this world today. And with that, thank you very much.
Thank you.
Thank you.
Thank you.